to increase health insurance enrollment for people who are homeless. My name is Stacy Fox, and I'm with the Technical Assistance Collaborative. Before the webinar begins, I'd like to take a minute to review a few webinar logistics and tips. On the left side of your screen is the viewer panel, where you will see the presentation materials. On the right side of the screen is the control panel that includes the questions box. You may submit written questions throughout the webinar by using this questions box, and we will read them aloud for you. Today's speakers will each present for 15 minutes. Following each individual presentation, there will be an opportunity, if time allows, to respond to a few questions. We will also have approximately 20 minutes for questions and answers after all the speakers have presented. Speaker contact information will be provided after each presentation and at the close of the webinar. The slides that will be presented today will be made available after the webinar. For those who registered, copies will be emailed to you, and copies will also be made available on the HUD Exchange website. Today's webinar is being recorded and will also be made available on the HUD Exchange. Now I would like to turn it over to Rula Swice, the Supervisory Program Advisor from the U.S. Department of Housing and Urban Development, who will open this webinar. Rula?
Thank you, Stacy, and hello, everyone. As Stacy said, I'm Rula Swice, and I serve as a Supervisory Program Advisor at HUD's Office of the Assistant Secretary for Community Planning and Development. In this capacity, I administer a Homeless Assistance and Healthcare Integration Technical Assistance Initiative we refer to as H². When homeless assistance and healthcare systems work together efficiently, seamlessly, and in a client-driven, recovery-oriented manner, the outcomes are exponential as compared to the outcomes we might see if these two service systems continue to work on parallel tracks. That is why we have been working with a range of partners at the U.S. Department of Health and Human Services and the U.S. Interagency Council on Homelessness to develop and implement this initiative with their support and endorsement. At the federal level, HUD and HHS recognize that our programs overlap and target some of the same populations, including people who are homeless. This TA initiative is designed to make sure that where this overlap occurs throughout the country, that service workers, case managers, administrators, policymakers, and practitioners working in both service systems have an intentional approach to coordinating access to the critical and life-saving housing and healthcare services that people with special needs have. The TA includes webinars like this one, but it also includes on-site action planning events designed to convene housing and healthcare stakeholders to chart a path forward for their systems integration efforts. When these systems do not work cohesively and are fragmented, there is a human toll. Fragmentation, lack of access, uncoordinated, misaligned referrals, and cold handoffs between homeless assistance and healthcare service systems result in unnecessary suffering, and in extreme examples of system breakdowns, people die. They get stuck in these gaps, which in some parts of this country look more like canyons. Here at HUD, we could not be more thrilled to welcome all of you to this webinar because it focuses on the most critical first step in addressing the healthcare needs of people who are homeless, ensuring that they have health insurance coverage, and this requires systems to coordinate. That is the focus of this webinar, and we've lined up excellent presenters who are not only leaders in their field, but have first-hand experience in successful strategies for enrolling people who are homeless in health insurance, and they will share their wisdom, suggestions, lessons learned, and resources with you today. In the spirit of true partnership, we've coordinated this webinar with our federal partners at HHS, including Health Resources and Services Administration, the Centers for Medicaid and Medicare Services, the Administration for Children and Families, and the Substance Abuse and Mental Health Services Administration. We've opened up this webinar to their grantees and stakeholders to encourage community coordination across the various funding streams. We welcome all the continuum of care, ESG, and HOPWA grantees and stakeholders, in addition to those of our federal partners. I encourage you to make use of this information and use the resources that will be made available through this webinar. HUD will continue down this path of improving the integration between homeless assistance and health care along with our federal partners, and we want to ensure that you are equipped and unequivocally know that you have our support at every step of your systems integration efforts. At this time, I am pleased to introduce my federal colleague, Donna Cohen-Ross, who is with us today representing the office that administers perhaps the most relevant form of health insurance for people who are homeless, Medicaid. Donna is the Director of Outreach Initiatives at the Center for Medicare and Medicaid Services. In this capacity, Donna helps to oversee CMCS's efforts to outreach to vulnerable communities. Donna, I'd like to turn the floor over to you.
Thank you so much, Rula. Just want to double check and make sure that you all can see my slides at this point. Yes, Donna, we can see your slides. Thank you. Good. Well, that means I went over the first hurdle of figuring out the technology. So it can only continue from there. Thank you so much for inviting me to join this webinar today. I'm very excited because I know that the speakers you're going to hear in a few minutes are folks who have a tremendous amount of experience and are going to share what they've learned over time in terms of the most effective ways to conduct outreach and enrollment for health coverage. And so I know this is going to be a very fruitful hour or so that we're going to spend together. But as an introduction, I wanted to share a little bit about what is happening here at the Center for Medicaid and CHIP Services, what we're focused on, and I think most importantly, at least for the work we're about to do together, share a little bit of the materials that we have available for you. And I hope that each and every one of you thinks about ways that you can take advantage of those materials, which are free and available to anybody. So why don't I get started with the first slide, and it really starts with our main message at the Center for Medicaid and CHIP Services, and that is enrollment for Medicaid and CHIP is always open. Anytime that somebody needs health coverage and wants to apply for Medicaid and CHIP, they can do that. There are numerous ways that they can apply. I think you've all heard about the No Wrong Door policy. They can do it through the single streamlined application. There are lots of places in the community where application assistance is available. I know you'll be hearing more about that. But as the open enrollment period for enrollment in a qualified health plan through the marketplace has now come to a close, we are ramping up with this message that Medicaid and CHIP is always open. And we are really pleased that our new enrollment report released yesterday tells us that we have more than 10.8 million new enrollees in Medicaid and CHIP so far. So we feel pretty good about the progress that we are making. And again, it's we in conjunction with all of you, because the work that you are doing in your own communities, that are the work that's happening all over the country, is contributing to that 10.8 million number. You may be familiar with this map. It is a map that is ever-changing, perhaps slowly, but still changing. This is a map that shows which states in green have taken the opportunity to expand the Medicaid program for individuals that have not been eligible in the past. Many of them are adults not raising children. There are others as well. In blue are those states that have not yet expanded. But this is another area where progress is being made. As of January 2015, as of last month, we have 28 states and the District of Columbia which have made the decision and are implementing a Medicaid expansion going forward. And these discussions continue to evolve with additional states interested in moving forward. So I think slowly we will see state by state more green on this map as opposed to blue. But one of the points that I want to make here is that there is work to do in terms of enrolling eligible people, people eligible for Medicaid and CHIP but still uninsured. There is room for that work whether you're in a state depicted on this map in blue or in green. We have many, many people who still are eligible for coverage but are not enrolled, and that's what makes the outreach and enrollment work so very important no matter where you are. And we have seen that with all of the messaging, all of the public education and outreach going on during open enrollment to focus people on coverage through the marketplace, we are seeing a bump up in Medicaid and CHIP enrollment. And of course that's because when people apply for coverage, they often don't know what they're eligible for. They simply want coverage, and that application process, that single streamlined application can be used by the system to figure out which type of coverage is most appropriate for that person. So we are seeing a tremendous effect of newly eligible people getting enrolled, but also people who were eligible in the past but for one reason or another had not applied and are now coming into the program, and we call that the welcome mat effect. When you put out that welcome mat and tell people that coverage is available, come in and apply, that's exactly what they do. They walk through the door. So one of the activities that has been going on for a number of years through the Center for Medicaid and CHIP Services is our Connecting Kids to Coverage campaign. That was a campaign that started with the reauthorization of the Children's Health Insurance Program and initially focused really on children who are eligible for Medicaid and CHIP but not enrolled. We have some new opportunities here because of Medicaid expansion in those 28 states and District of Columbia, and also because of that broader health coverage message to not only focus on children but also their parents and other family members who might be eligible for coverage and have not yet taken advantage of that opportunity. And so what we are trying to do is find and enroll all uninsured children and teens and their parents who are eligible for Medicaid and CHIP and get them enrolled. And again, it goes beyond parents, particularly in the states that have expanded coverage to other adults. We have materials that we've created. They can be customized. I'm going to talk about that in a moment, and distributed through your programs. They can be used in a variety of ways. We have print materials, video outreach materials. We are very focused on engaging partners who have local affiliates across the country. Some of the folks you're going to hear from today are those partners, and we're very pleased to have them and to work with them and their local affiliates so that we can reach out with this message anywhere there are people who are eligible but not enrolled. We also are encouraging and demonstrating the use of helpful enrollment policies and outreach strategies, which I hadn't planned on talking about today, but certainly in the Q&A period I'm happy to answer questions. I want to just very quickly give a broad overview of just some of the very general rules of thumb, and you're going to hear about these in a lot more detail in terms of effective outreach strategies. We know that making consumer-focused outreach materials available wherever community members gather is a really important first step. In my mind, there is nothing more important than incorporating application assistance into program operations. So that could be connected with intake for your program. If you're a health clinic or working with a health clinic, making sure that there's an opportunity for application assistance there. Maybe your program is associated with Head Start or an after-school program. These are all opportunities to incorporate application assistance, and that's really where the rubber meets the road in getting somebody health coverage who's eligible but doesn't have it. We know that it is a very important thing and a successful strategy to reach out and enroll families when they're seeking health care and to emphasize covered services. So through our Connecting Kids to Coverage campaign, we think about times of the year when families and individuals are very focused on getting health care they need. So for kids, for example, it's back to school time. Asthma and allergy season is really important. Cold and flu season. Some people have said in some parts of the country asthma and allergy season are year-round, so that's okay. We have materials that are focused on that message as well. But the point being that when people are seeking health care, when they need help, when they're looking for dental care because someone in the family or themselves is dealing with dental pain, that's a really good time to address the problem, but also talk about enrollment in health coverage so that that person can get ongoing care and care for other needs that might not be pressing at that moment. We always want folks to tailor the message and assistance that they give to special populations that you may serve. So there's maybe special messages you want to convey for families with immigrant members. I know we'll talk today about working in communities with people who are homeless and how tailoring the message there might be really important. These are just some rules of thumb that are just kind of central to effective outreach work. Now I want to just very quickly buzz through some of the resources that we have. All of these are available on insurekidsnow.gov and some which I'll mention in a moment on medicaid.gov. But we have outreach materials including customizable flyers. You'll see a bunch of those in a moment, and by customizable I mean we will, for free, put your logo, your phone number, some identifying information about the program in your state. Sometimes the program has a different name. There are a number of items that can be customized. We will do the design work for you, and you're responsible for the printing, but we can create the design for you for any of the materials that we have. We also have training through a webinar series that everyone is invited to participate in. We have a campaign notes e-newsletter that announces when those webinars are, when new materials are available. All of that and signing up for all of those things can be done through the Insure Kids Now website. We have a host of public service announcements, radio ads, sample articles for print media. All of those things, again, are available, and we encourage folks to use them. Just a little set of examples of the kinds of materials that we have. You can see these messages are really focused on kids and children and families. Everything that we have is available in English and Spanish. A number of the materials that we have are available in other languages as well. I like this little guy because he just seems so smart, but also this is one of our pieces that also focuses on the availability of coverage for parents. We know that there is, particularly in states that have just expanded Medicaid, there might be a need to be to present the basic facts about the program for consumers, and so we have a new set of fact sheets at the link that you see here. And again, I want to just buzz through that so that you can see we have a wide range of images that you can use, and again, these are all customizable. These are just some of the images that we have. We have pretty much the same flyer, sort of tailored. This is for states that have expanded Medicaid. We have a similar piece for states that have not yet expanded Medicaid, and we have a set of materials that are focused primarily for American Indian and Alaska Native communities. There are some very particular things that we want folks in those communities to know about Medicaid and some of the special protections for American Indians and Alaska Natives. Again, all of these materials are available on our website. They are free, and we will customize them for you, and we hope that you find them useful. I will be happy to answer questions when the question and answer period comes around. I am now going to turn it back over to Rula, and I, along with all of you, am very excited to hear what the panel has to say about their outreach and enrollment experiences.
Thank you very much, Donna. Here at HUD, we are so grateful for this partnership with CMS, and we look forward to continuing this partnership with you and the agency you represent on behalf of the people that we are serving. So thank you for that presentation. At this time, it's my pleasure to introduce the very esteemed panelists who will be presenting the material to all of you. Our first presenter is Jessica Kendall. Jessica is the director of the Enrollment Assister Network at FamiliesUSA. In her role with FamiliesUSA, Jessica works with enrollment assisters to identify best practices and technical assistance in enrollment-related activities, and to share those lessons at the national, state, and local levels. Next, you'll hear from Barbara DiPietro, who is the policy director for the National Health Care for the Homeless Council, and also the Senior Director for Policy at the Health Care for the Homeless of Maryland. In these dual roles, she is able to focus on national, state, and local health policy with a specific aim to ensure that the implementation of the Affordable Care Act accommodates the unique needs of homeless populations. Barbara will also be serving as the moderator for the panel for the rest of this webinar. Katie League will be our next presenter, and she's the Outreach and Enrollment Coordinator at Health Care for the Homeless in Baltimore, Maryland. As an outreach worker, Katie works to connect individuals who are often hardest to reach due to mental illness, substance use, and chronic medical issues with care. She coordinates the outreach and Medicaid enrollment efforts at Health Care for the Homeless, as well as their mobile clinic project. And finally, our last but not least presenter will be Kristin Lupfer, who is the project director of the SAMHSA SOAR Technical Assistance Center at Policy Research Associates, Inc. The SOAR TA Center works to increase access by homeless persons with mental illness to the Social Security Administration's Disability Income Benefits Program. Kristin oversees all aspects of the SOAR TA Center, including delivery of on-site TA and the development of the SOAR online course and technical assistance to SOAR states on strategic planning, collaborations, funding, sustainability, and implementation. At this point, I'll turn it over to our moderator, Barbara, and thank you all very much for joining us once again. Barbara?
Thank you, Rula, and thank you, Donna, and for all of you coming today to talk about this. Really appreciate the partnership that our federal friends have shown at CMS and at HUD. I can honestly say that in the years I've been doing this work, this is really, we're seeing so much more collaboration at the federal level among those agencies, and that's really mirroring the partnerships, the integration, and all of the coordination that we're doing on the local level. And so it's good to see so much synthesis happening at so many levels. I know we're all excited to hear what folks have to say, and so with no further ado, I will turn it over to Jessica Kendall, who can talk to us about the FamiliesUSA perspective. So Jessica, take it away.
Wonderful. Thank you so much, Barbara. And thank you so much for this opportunity to be able to chat with you all today. So for those of you who aren't familiar with us, FamiliesUSA is a national consumer advocacy organization. And as was mentioned earlier, I'm the director of the Enrollment Assister Network. So I spend a lot of my time talking to folks around the country to learn about what are they doing, how's it going, and what do they need. And oftentimes I spend a lot of time brainstorming with enrollment assisters about who they can be partnering with and how they can be reaching out and finding uninsured folks, which also means I spend a lot of my time talking to folks about how they can be partnering with you all, which is what I'm hoping to talk about a little bit today. So I want to just pause here and take a moment to get us all on the same page. You know, we've had a tremendous success over the last couple of years, and we still have a lot of work to do. And I think that when I think about healthcare and who we should be reaching out to, I think there's three legs of this stool, and it's really hunger, housing, and healthcare. And if somebody has an issue with one of those, or if one of those is prominent in their life, then there probably has an issue with all three. So regardless of whether or not your state expanded Medicaid, I want to talk about how we can connect people to services, what consumers may not be hearing or seeing, like you see on the screen right now, and then what we can be doing to coordinate that work. So, if you were to go to healthcare.gov right now, which for almost everybody in the country, for majority of places, if people are hearing that there's health insurance available or there was, they're going to be directed to healthcare.gov. And what they're going to see is that open enrollment is over. So I'm so grateful for Donna's presentation, and I think you're going to see a bit of overlap between what we want to say to you, because I think it's important that we get this message out that Medicaid and CHIP are still available. And when you're looking at this screen, the two things I really want to flag is, yes, open enrollment is over, but see if you can still get coverage, because there are folks out there, yes, for Medicaid and CHIP, and also if somebody had a change in their life, like they had a baby, or they got married, or they lost their job, or they got a job, if they had some kind of change in their life, there still might be coverage available for them. The other key thing that's going to be essential on the screen is find local help. And that is what I want us to be talking about a lot today, and for you all to be thinking about for those connections. So on the next screen, what you'll see is just a snapshot of what we're looking at. So open enrollment, as well as just the creation of the Affordable Care Act, means that over 21.5 million people now have health insurance, which is extremely exciting. I put these slides together at the end of last week, and these numbers have already changed. So in blue, you see 10.1 million. That's now at 10.8 million. That was the number that was released yesterday. So 10.8 million people now have been able to get Medicaid, and those numbers are actually based on reports from December. So we know that people want health insurance. We know they've needed it for a very long time. Before the Affordable Care Act, there is an estimation, and it depended on what data you looked at, but somewhere between 40 and 50 million people were uninsured in this country for a variety of reasons. Well, we know that over 21 or over 22 million people have gotten health insurance, which is a tremendous success and extremely exciting, but it also means that there is a lot of work to do. And what you'll see on this next slide is a vision of what's going on around the country, similar to Donna's, but where has Medicaid been expanded? In states where Medicaid is expanded, I think especially when you're reaching out to homeless populations, there's a much more clear door, maybe not a pathway through that door, but a much more clear door of what program to get them enrolled into and how you can help them apply for coverage. But in those places that haven't expanded, in Texas and Florida and Georgia and quite a few states around the country, I think it's important to, make sure that people are still applying for services, because as Donna mentioned, there is a chance that they actually might be available and may be eligible for Medicaid, and maybe they always have been based on the state that they live in and their income levels. The other thing is, just because somebody, and you all know this, that just because somebody doesn't have Medicaid available or isn't able to get a qualified health plan, that doesn't mean that they don't need health services. So thinking through how you can connect them to the available health services and what that process looks like in your organization. There's a variety of different folks on the phone right now. So maybe you are connected with a health center already, maybe you aren't, maybe your organization doesn't have capacity to do that real warm handoff. Let's think through how we can partner with groups to make it easier for consumers to get the services that they need. And what you'll see on the next slide is that the reason that people still remain uninsured, and obviously, if you're in a state that hasn't had a Medicaid expansion, that's a pretty significant reason. But it really falls into this idea and fact in places that getting health insurance is too expensive. You simply can't afford it. And part of that being too expensive is that, quite frankly, a lot of people don't realize that there may be something available for them. So if you're in a state that's expanded Medicaid, this fact or statistic still applies, because consumers might think that they don't actually have something available for them because the information that there is Medicaid available hasn't actually reached them. So on the next slide, I wanted to break down what it actually means to be Medicaid eligible. And this is for states that have expanded Medicaid. But for a single individual making, less than $16,000 a year, they're going to be able to apply for Medicaid and ideally get enrolled and be able to have their health coverage covered. Now, I did some work in Florida last year, and I very much understand that a lot of people apply and, quite frankly, are told that they don't make enough money in order to apply, in order to afford to get health insurance, and that they would have to pay the full cost, which is a tragedy. And Families USA is doing quite a lot of work to help those states that haven't passed Medicaid expansion to get that passed. In the meantime, it really goes back to, and you'll see this on the next slide, connecting consumers to folks that can help them navigate the system. So there is some work that was done by Enroll America where they looked at who is more likely to actually get enrolled, right? So you sit down with somebody and help them apply for coverage rather than sending them to healthcare.gov or to whatever their state website is. If you sit down with them and help them apply, they are twice as likely to actually make it through the system. And that's for a variety of ways, but it really applies to all populations. You know, people who haven't had exposure before to navigating the health system or applying, it's rather complicated, and it's been simplified a lot from where it used to be, but that doesn't actually make it easy for consumers, and especially when you start looking at literacy levels, language barriers. So the more that we can connect people, live people that they can sit down with and apply for coverage, the more likely we know people are going to be successful in navigating the system. Now, in every state, and you'll see this on the next slide, there are folks available to help people, and y'all come from a variety of states, and these people have a variety of names. From a federal perspective, the names that you see really are attached to funding streams. The one I want to pick on for a moment is the third one down, called Certified Application Counselors, and I want to pick on them because I will end up calling them CACs. It's just easier and shorter. So these folks are all looking for uninsured consumers. They are either volunteering to look for uninsured consumers, or they are paying or getting paid to look for uninsured consumers, and you all have access to them. So it's a very natural partnership to connect with these folks and figure out how the folks that you're interacting with that are uninsured can get connected to them, and that way those consumers or patients or clients or whatever, whoever you're working with, that they can have somebody hold their hand through the process. Now, on the next slide, what you'll see is just how important that is. So it's important to have somebody holding their hand, and it's also important to make sure that those people whose hands will be held hear that coverage is available multiple times. So it's not just about, you know, somebody coming into a shelter or that one-time contact with somebody and saying, hey, you know, go talk to Katie and apply for health insurance. The more times you tell somebody that coverage is available and where they can go to for help, the more likely they are to apply. And if they're sitting down with somebody to help them through that process, the more likely they are to actually get enrolled into health coverage. So on the next slide, I wanted to highlight some messages that help reach the uninsured. You know, and I think that the two that are going to pop and will make sense, because I keep saying it throughout this webinar, is that you might be able to get financial help to help pay for health insurance. You know, the key thing is folks don't feel like this applies to them, right? Over 20 million still remain uninsured. So letting them know that there may be a plan available and that there is somebody who can help them apply in person right now gives folks that motivating factor. Now, what I want to highlight is the reality of a lot of your guys' roles, and I understand how incredibly busy so many of you are. And on this next slide, I wanted to brainstorm a little bit about what are those touch points that you have. What can you do, and how does it actually meet both your mission and your bottom line to get those folks that you're seeing to help them get health insurance? So I was in Oregon at the beginning of February, and I went and met with Central City Concern, which some of you may be familiar with. They have about 1,600 affordable housing units. They provide a variety of services. They're also a federally qualified health center, so that may or may not apply to you all. But what they were able to do is hire 2 full-time outreach and enrollment specialists in October of 2013. And since then, they have enrolled over 3,200 people, and about 20% of those folks that they enrolled into health insurance in Oregon came from outside of Central City Concern, mainly from local homeless partner agencies. and 95% of the folks that they enrolled went into Medicaid. So if you happen to not be a health center, you can still be connecting with a group like Central City Concern or another one of these entities that exist in all of your states. Now, the thing that really impressed me with Central City Concern is we started talking about numbers, and I'm going to list off some statistics for you. So follow me a little bit here because it's very relevant. So what they said is that their insured rate in their health center went from 54% in 2013 to 85%. So they had an incredible jump in what their payer mix looked like in their health center, which really just meant that their medical billing revenue doubled, and their Medicaid revenue tripled in that same period. So because by simply hiring these staff and having those staff enroll people into health insurance, and they're serving predominantly low-income and homeless folks in Portland, Oregon, they're able to change their payer mix, and then they were able to use that excess revenue to expand and improve their current health services, develop more affordable housing, and fund services that aren't billable to Medicaid. Which means that for those of you that are listening, you might be able to either change your payer mix by figuring out how to enroll folks in your health centers, or you may be able to connect with somebody who will be able to do it as well. So there's a financial incentive for folks to actually get folks enrolled, as well as helping meeting all of your missions. So when you're thinking through what you can do as an organization, think about how are you currently connecting with health centers, because health centers have O&E staff that are looking for uninsured folks. Do you have volunteers? If you have folks that are volunteering at your organization, could you get them trained as a certified application counselor, as a CAC? And could that group that is trained, could they help people who are coming into your homeless shelter and help them navigate the system so that way you're not taking your staff time to do it, but you're utilizing your volunteers to really help better support the services that your clients may need. So where are those touch points in your organization? Now, on this next slide, I want to just take a step and take a moment and kind of sum this up to think through, you all, again, are extremely busy. So do your social workers, do your case managers, do they know where people can get care? Do they have those referrals built in? And if not, what's the easiest way you can build those into people's work? And how can you make sure that in all of the work that you do, at a baseline, your folks that interact with clients are able to say, here's where people can go and apply, right? Here's that partnership that we've created, which may be as simple as answering an email from somebody who's reached out to you, or picking up that phone and calling that local navigator to say, let's figure out how we can partner. I know in Ohio, the Ohio Association of Food Banks is a navigator grantee, and they have a sub-grantee that sits in a homeless shelter once a week every afternoon to help people get enrolled into Medicaid. So they're looking for uninsured folks. But really, when you think about this next year, knowing that Medicaid and CHIP are open all year round, how can you figure out where your touch points are and make that plan, build those partnerships to reach out and get consumers and the folks that you're seeing either enrolled into health insurance or connected to places that can provide care. And I believe we are going to be opening it up to questions at the end, so I'd be more than happy to take any questions after the other wonderful speakers. Thank you.
Thank you so much, Jessica. And I'm just going to, we're pulling up slides here on my end, and that'll go. Just again, really impressed by the turnouts today. We've got over 460 people, and so clearly this is hitting an interest area. And I think a lot of this is really just figuring out, what are people supposed to do? There's a lot swirling around. There's a lot of information. And people have a lot of different ideas about what is supposed to be happening. But really just for housing providers, shelter providers, meal programs, HOPWA, a lot of folks who are providing services that are not traditionally in the healthcare sector. I think this is really why we're trying to drive a lot of integration between the alertness that you can be providing and then the referral or the assistance that you can be doing. And really, there's a broad range of health services that all of this is trying to connect our clients to. Really what we're trying to do is stabilize and improve health conditions. The idea is not so much to get people insurance. The idea is to get people the services that the insurance facilitates. So we're trying to think beyond a card and really thinking about how do we get access to the services that people need. Now, we've talked about health centers, federally qualified health centers, or health care for the homeless, or a number of places that will provide care without insurance. But Medicaid can provide access to specialty care and a broad range of services that we can do outside that we can't do in the primary care setting. There's really a limit to what we can do in a health center. And so just thinking about, how are we connecting people to the breadth of services that they need. And at the end of the day, that really stabilizes their health. It prevents relapse, and it really prevents people from getting worse. And when we think about, a lot of times we say housing is health care, but when I think about why this is important for housing and shelter providers, I think about it in the reverse, is that health care is housing. In places where maintaining sobriety or maintaining goals or maintaining a certain level of functionality is really important to continuing to qualify for your program, a relapse sometimes can mean that they get kicked out of housing, that they get kicked out of the program. And so when we can best connect people to the care that they need, it means that we'll really lessen the occurrence of relapse, and we can really do interventions in a timely way so that we know that people really can not only be stable in their health, but they can be stable in their housing as well. And I think another piece that's really important is that housing and shelter providers and HUD-funded folks, you don't need to be an expert on the Affordable Care Act or enrollment or be able to recite all of these statistics off the top of your head. That's why we're here, and I think what we're trying really to do is emphasize various ways that you can connect to us or that we can connect to you, and we're trying to build these bridges. But all of these partnerships are really going to look different depending on your local programs, what kind of programs you are. Some of you are running really sophisticated large programs where you have no problem. You've got a volunteer corps already that can be redeployed or assigned to do insurance enrollment. Some of you are running really small programs and just don't have that kind of capacity. Some of you are working in expansion states and some of you aren't. And some of you have got really great local relationships with your healthcare providers, and some of you either may have a rocky one or just really are looking to where you can connect with those kinds of connections. And so really I'm just looking at the areas of greatest change for us as healthcare providers are on outreach and enrollment, what our clinicians are seeing, and then what delivery systems are changing on a larger scale. And really all of this brings opportunities, but there's also challenges that we should be honest about and really seek to address. But again, this is all about making sure that people are connected to the benefits and care that they need. Jessica had mentioned Portland, who is shown on this graph, and really it's only to show that everybody is in a different place. If you're in a non-expansion state like in Jacksonville, Florida, you're not going to see much change in your homeless enrollment at your healthcare for the homeless client. But then you'll see, like in places like here in Baltimore and in Portland, they exercised some state options where they were able to see some really quick and fantastic increases in the numbers of clients that they're seeing who have insurance. And then you see, people who are in different places for various reasons. So again, what your line might look like in your community will be dependent on a lot of factors. And so if I can just synthesize what our outreach and enrollment workers are seeing nationally. We've done a lot of focus groups. We've done some partnerships with the Kaiser Family Foundation. We've been doing a number of other initiatives to try to identify the themes. And as has been mentioned earlier, really most of the people that we're seeing are Medicaid eligible, really emphasizing that there's no close to the enrollment. It seems like we're all hitting that point, and so that's something that's obviously very important. Again, focusing on the services that people are needing, but the clients have really been excited to enroll, and at first we thought that they might not, but that's been really pleasing, and that they can help spread the word with other people, and that what we're seeing is that clients are referring other people to us. And again, the engagement and care is clearly the key from a healthcare perspective. But we need to be honest with how the systems are developing, where some of the glitches still remain, and making sure that people don't just get enrolled, but they're also being re-enrolled, that they're not getting dropped along the way. And then we need to make sure that insurance is a new concept for a lot of people. So how you use it, how you make an appointment, how you navigate benefits. Anybody who's spent any time navigating their own health insurance benefits knows knows how complicated it can be. When we talk with our service providers, and these are doctors and nurses, these are mental health therapists, addiction counselors, case managers, and a wide range of people who are doing care, what we're finding is that clients are getting greater access to services. When people get a Medicaid benefit, all of a sudden now we can refer them to get surgeries, get chemotherapy, get really specialized and in-depth care that we know they need but have just never been able to provide them. And a lot of places it's a ad hoc pro bono kinds of services that we need to make sure we secure for folks. But that's not a system. That's usually begging, you know, and with hat in hand to get a cardiologist appointment. So what we're really focusing on now is more systemically we can get people where they need to go, and we can get them better care. We're seeing third-party billing. So now that we've got clients who have health insurance, we're actually able to bill that health insurance. And with that comes a greater reliance on a funding stream through billing that's a lot more stable than relying on grants. That's not to say that grants aren't still vitally important to fill the gaps that Medicaid has, but this gives us a little bit more stability as providers to be able to think longer term. We're doing more hiring because now we actually have a more a stable funding stream. Sometimes grants, it's a little dicey to hire when you don't know what the long-range plan is going to be. And so we're finding ourselves really adjusting to steadying the ship, and that's exciting. And so what we're seeing is that as clients are getting engaged in care and as clients realize, hey, they have choices on where they can go. We've had clients who have, when they realized, hey, you have 5 different insurance plans that you can enroll in, and this insurance plan means you can go to this hospital system, or there may be different hospitals and different plans. Clients have a real desire to go to the place where their clients have said, I've walked past these 2 hospitals so that I go to the public hospital, because that's the poor people hospital. And in communities where the poor people hospital is really, you know, the only game in town for homeless service providers, now we are seeing a change in relationships for us. We're seeing not only are we able to connect our clients to all hospitals really, but we're also finding that we have greater relationships with the service providers in those hospitals. And so this is a change for us as well. We have greater partnerships and partners in care just like our clients. But we also need to be honest too that with billing, you know, with Medicaid comes incredible access to services, but it also comes changes for us in a homeless service provider environment. One thing that really has been key and stood out is the greater administrative burdens. Prior authorizations, sometimes writing scripts or getting permissions to do different services for folks means that we have to delay access. Sometimes plans change their formularies, and so we might write a script where one day it's covered and 2 weeks later it's not. And sometimes you don't realize that your patient is now either the service isn't covered or you weren't given authorization for it until the client is standing at the pharmacy. And sometimes when someone's told, hey, that'll be $80 and you were expecting it to be $1, you know, that creates stress for anybody. So these are the kinds of things we're working through. We know that Medicaid doesn't cover everything, and so we really have to be reasonable about, you know, what are some gaps in the system that still make those grants really, really vital? Case management in particular, but then also adult dental is not typically covered by Medicaid. So, you know, how do we fold that in? And then at the same time, too, while it's fantastic to be in a mainstream insurance program like Medicaid, we still are seeing fragmentation and inconsistencies. When you've got some areas have got 2 plans, some areas have 20. And so when you've got 20 different formularies for your pharmacy, and when you've got, you know, different provider networks or hospitals here, there, and the other, we are still seeing some fragmentation and figuring out what all this means for us as providers who are then having to create treatment plans for our clients. This is all a changing environment. So I think part of this is the changes for clients and for us really is kind of just, it takes a little time to get used to those changes. And then at the delivery system level, so this is really where we're trying to go with the macro level. We're trying to get greater coordination and integrated care, and we're trying to, now that our patients are engaged in the system and they're no longer uninsured and kind of outside the mainstream, what we're seeing now is that we can focus on different areas. We can focus on quality of care and care coordination. We can figure out how we get a patient from one care venue to another care venue in a seamless way. We're looking at changing payment models in many states or even localities, and this might be through your hospital system where now they're paying, or there's incentives not to have readmissions, or you're seeing changing payment models at the macro level, like accountable care organizations like they have in Portland, Oregon, or again, you'll see lots of different, pay for performance or pay for outcomes. So a lot of this is changing how care is delivered. And if it's not yet felt in an implementation standard, definitely you're seeing that on the planning table in just about every state. So a lot of this brings ambiguity because providers may not really know yet what this means for them. But still, again, it's a lot of changes happening all at once. But one of the things that I have found really exciting is that there's an increasing focus on social determinants of health. It used to be that if you went to a meeting and somebody said something like, well, housing is health care, that would be a radical statement. And there might even be a gasp and everyone would look and see who had said it. Now, that's an accepted premise, is that people are looking at housing, employment, place matters, nutrition, poverty, all of these things that we know influence health status. These are the things that now increasingly we're not just looking at in a public health perspective, but now you get Medicaid directors talking about social determinants of health and the connection between health status and housing. And that's really light years from where we were even 5 years ago. So I find this a really exciting system change. We're looking at, targeted benefit packages or targeted interventions to frequent users, and maybe to hospitals, but sometimes also to correction systems or to other frequent users, frequent 911 callers, frequent ED users, things like that. So how can we be doing interventions there so that we can get people the coordinated community-based care that they need? And then again, the data systems. We're all in an environment now where greater data is really what we're driving toward. And I know there's a lot of talk about who has access to what data and what elements and what systems and who can see what. And these are really the details we have to work through. But as providers, when we can see when our clients have been in a hospital system and we can see what happened to them in the ED, and we can see when they were discharged, and we can coordinate and communicate with the physicians that are in the hospital system and the community, that really creates efficiencies so that we're not faxing things back and forth and spending more time chasing down each other's paperwork than we are actually providing care to the client. So there's really a lot of opportunities here for us to do that better care. And so 5 challenges. I hit on a couple of them, but I just want to hit them real quick. Making sure the clients are staying connected to care. And so this means getting connected to benefits, making sure the benefits don't lapse, and that they're connected to a community provider that can serve them. And so these are all very distinctive steps that are very important. We need, and we all know this, we know we need to grow our housing capacity locally. We know we need more housing stock. And the ACA didn't create new housing, but it does create an opportunity for us to be working together. And I think that there are efficiencies with our resources that we can squeeze more out of this. And so how do we grow our health services locally? Now that we have funding for this, we can pay for more of it. And wouldn't it be a great opportunity really for us to be able to build more health care in our communities? And building not just anyone to serve people experiencing homelessness, but building a provider community that has the core competencies and the desire and the motivation to really treat a high-need population that may not have a waiting room presentation that some private providers might prefer. So what we found sometimes is that clients might leave us and go somewhere else, but what we found is that they come back because they weren't treated with respect. We need to advocate to make sure that we can fill the gaps in Medicaid. So figuring out what local or state funding we can identify, or advocating for some waivers or some changes to Medicaid to add benefits, but making sure that we've really got comprehensive care available. And then really the patients is the hardest point. I think it really takes time for new systems to develop and for everybody to kind of figure out how these work. And so that's going to take a little time. And of course it takes time to build local support and figure out how these systems are interrelated. And I think that's really a key that we've all been focusing on. But I think where we really want to focus at macro level, there are so many opportunities here. Obviously, with the coordinated access that HUD is rolling out right now, we have an opportunity to really consider what are the healthcare needs of our clients who are both in the health and housing communities, and how do we build a system that can meet those needs. and how do we create stronger clients, stronger engagement in their own care, and how that now that we have a Medicaid benefit that's really consistently available to a lot of people, we have something tangible we can offer folks, not just benefits, but folks typically will tell you what care they want to receive, and they are more than eager to access it, and they're more than eager to partner with you to make that happen for them. So I think that's really exciting. We're starting to see the idea that we can connect recidivism in the justice system to access to care. The idea that if we can actually be getting people into the behavioral health system in the community at full federal funding, then we can prevent that stem from mental health and addictions into the jail system. And I think that's really a great opportunity. And also into the social services system. If we don't have the level of untreated addiction in our parents, then we might see fewer kids coming into foster care. Again, these are real visions, but we have an opportunity to really pivot to include those visions in our planning. And again, it all comes down to having healthier families, more stable community. We really have an opportunity here to stabilize people in a way that can prevent and end homelessness through their health care, but that takes all of us really working together to make sure that not only do they have good health and health care, but they've got a stable place to stay. And when we've asked clients, even in our waiting room here in Baltimore, what would be your 3 wishes? These are the kinds of things that people say when asked, totally unprompted. These are the things that are on their mind. They want to get their health care conditions under control. And these are the things that they're identifying as their own goals. And as healthcare providers, we're here to meet those goals and make sure they get connected to where they want to go. But partnering together with you in the housing and shelter community, really want to make sure that we're being comprehensive in our view. And so we've got a number of resources on our national website, a lot of tip sheets, quick guides, policy briefs. Please let us know if there's something that you're looking for that you didn't find there. And with that, I'll turn it over to Katie League, who can talk to you about really what this looks like on the ground from her perspective as Baltimore's Outreach and Enrollment Coordinator.
Good afternoon, everyone. I just want to take a little time to inform you about what we have seen. There was so much excitement around the Affordable Care Act and so much buildup that we now have had a full year where these people who were eligible could be enrolled, and now we're on to our 2nd year, and we've had an opportunity to look back and kind of think about what it was that we learned from it and ways in which we can improve our 2nd year of outreach and enrollment. So Maryland had committed to expanding Medicaid even prior to the ACA being upheld by the Supreme Court. So we had made a statewide commitment to expanding Medicaid to single adults. And so we had those opportunities to take advantage of some of those local things that were unique to Baltimore, unique to Maryland, and we really encourage you who are in states who haven't expanded yet to see what systems you might have in place that might make, when you do decide to expand, that might make that process a bit smoother. And for us it was looking at, we had a state-based program called PAC, which covered primary care. And the state worked through the waiver system to be able to get that automatically rolled over because the income requirements were actually lower than those for Medicaid, and thus everyone who was eligible for PAC was also going to be eligible for Medicaid. So we had a really wonderful jump on January 1st that sparked the excitement for clients, it sparked the excitement for providers to see the difference that this would enable for our clients in terms of accessing different types of care. And here in Maryland, most single adults did not qualify for Medicaid. They might have through the disability eligibility. However, for individuals experiencing homelessness, we find that that criteria is very arduous for them to meet, much to what most of you are probably experiencing in terms of inconsistent care, lack of the vital records, the medical documentation of those disabling conditions, and just in general, the process or the length of time it took for them to complete that application. We had anticipated a few issues back in 2012, 2013 when we were preparing for this, what we thought we might see. We were afraid that clients might not want insurance. They wouldn't know their necessary vital information, birth date, Social security number, that health insurance would be too complex to explain. You get huge packets whenever you enroll in new insurances, and that can be incredibly overwhelming since a lot of that material is very robust and often written at education levels that are beyond what our clients are able to comprehend. And we weren't sure how the online verification would proceed, the ID, the verification of identity, the verification of the proof of income, and at some point we thought we'd probably hit a saturation of need, that we would not see clients, that we'd stop having clients come in that had no insurance, that at some point we would hit everyone in the homeless population that needed insurance would already be enrolled. And that we would find that we'd run out of clients who were eligible, and that we'd have difficulty finding those who really needed the eligibility assistance. What we found was pretty different. Leading up to January 1st of last year, we had so many clients that were able to say, you know, for the first time, there is a light at the end of the tunnel, that January 1st, I'm going to have this insurance that will allow me to gain access to care that I really needed, or I'm holding off on this surgery because my doctor won't approve it until I have insurance to be able to pay for it. But it really is impacting my quality of life. So clients were really receptive, and what the outreach and enrollment team's responsibility was to really talk about how what it meant for that particular individual. So it required a lot of outreach, patience, and it really was talking one-on-one about what this meant for the individual that was sitting in front of us. So we stopped talking about the ACA as a large bill, as a large system that was going to impact, you know, that talking about Medicaid as a whole healthcare system, but actually talking about what the benefits meant for the individual sitting directly in front of us. A couple things we've also found as the year moved on and we started into the second year of full eligibility, there seems to be an ongoing need for enrollment. We have a couple potential causes that we've identified. The frequency of incarceration, that when somebody who might have insurance, if their benefits either lapse or they've been incarcerated long enough that their benefits are turned off. So when they are released, they need to be re-enrolled. The lack of a stable mailing address or email address. The system still does depend on being able to mail that red and white Medicaid card. And if a client does not have a stable mailing address, and their benefits might get cut off if they get lapsed, if there's a notification that's received in the mail and they don't get that notice in a timely manner. And we're also finding that applications are being completed and not approved, or approved and the information is not making it into the state system for a variety of reasons. And I'll touch upon a couple of those moving forward. And the redetermination process. Medicaid's not a new program. This eligibility category is new, but the requirements are the same, that the client redetermine their eligibility once a year. And so when that's happening, particularly here in Maryland, because we had one state-based system and we made the decision to go with a new state-based system, we've had to recollect all of that information. So doing it again for the first time, as they say. So what we have found is, due to some of those challenges, particularly last year, there were significant difficulties with actually navigating the website, understanding the benefits. And this is something that us, you on the continuum of care and homeless service providers, federally qualified health centers, we're very used to having to kind of jump through those hoops. So it's a great opportunity for partnerships there. We faced a couple technical challenges. The creation of username and passwords. As you probably know, you have millions of them for your different email accounts and financial documentation. Many of our clients have never had to go through that process of coming up with a uppercase letter, a lowercase letter, characters and numbers, and then remembering that information. So our team worked to develop different ideas that made it uniform, not uniform passwords, but things that were unique to the client that they would remember. Mother's maiden name or middle name that they, or childhood nickname, the year that they were born, and then either an exclamation point or a question mark or something that they're familiar with. As Jessica mentioned, there were different levels. We here in the Healthcare for the Homeless in Baltimore City have 4 certified assisters. For a variety of technical issues, we never gained access to what they call the internal portal, or the ability to see anything different than the average constituent. So there was several challenges of being able to try and move the application along, but having to actually call into the exchange to make that happen because the certified assisters did not have access to that system. And incarceration status. This is a huge one, and I know that this happens in every state, that those incarcerated statuses are determined either on a federal or a state level, depending on what system the individual is incarcerated in. And the exchange requires that data to be updated regularly. And if any of your states are like us here in Maryland, a lot of that is still done relatively by hand. There's not a real robust electronic system, and it's a lot of old data. So there's significant issues of people looking as though they're still incarcerated even months after they've been properly released and are in compliance with their release. And because these are new systems, we're seeing that new systems are linking with old systems. As I said, Medicaid is not a new system. So in Maryland, we've had a system that has taken in all of the Medicaid eligibility. So we had clients who maybe were eligible either under a maiden name or as a child. They lost that eligibility when they became an adult, but now due to a variety of circumstances may be eligible again, but now that data is old. So they have a maiden name, or because of a data entry issue, there was a misstrike of a key, and suddenly you have to get lots of documentation to prove that it is the same person, and it was just a matter of data entry issues. Really what we have found is that outreach is what makes the difference, is going to where clients are, recognizing that there are a variety of health conditions that the individuals might be experiencing. And you in the continuum may not be addressing, you might not be responsible for actually treating or addressing each of these conditions, but just knowing that they exist and knowing that they're going to influence the person's experience and how they go through the process of enrolling in insurance is really significant. And partnering with these sites that have CACs or navigators or assisters who are certified and see the website several times a day are going to be what makes this successful. Some of the things that we saw in engaging clients, big fears of medical bills. As you in the continuum know, medical bills do impact clients' credit history, which means it might impact their eligibility for housing. Not all housing, but some housing does look at that credit history, and medical bills can really negatively impact that. And there was just so much misinformation out there about the Affordable Care Act. So much of the work that we spent on outreach once we hired the assisters in 2013 was really to get them on the ground and talk about what it meant for the client. So we started reaching out into different sites where we knew clients would go. Those who come into our health center, they're already a leg up because they're interested in some form of health care, whether that's addiction services, medical, mental health, case management. But there are a lot of clients that go and that go to sites that provide more primary services, meals, drop-in centers, places like you all operate that serve clients, maybe not medically, but serve clients in very essential ways, and clients turn to you because they trust you. So really what we've learned is that in-person assistance is a great equalizer. Having somebody there to explain it for that particular individual is what made the difference in helping a client be willing to enroll and then successfully make it through the enrollment process. And this is where you guys are all so incredibly busy with your responsibilities that this partnership is going to be essential, because having providers who can not only complete the application, so my team of assisters is completing the application, but they're also tracking it, making sure that it actually becomes active, because completing it is one thing. The second thing is making sure that it actually gets turned on and that Medicaid gets sent out, that Medicaid card gets sent out. And how we have found this has been essential is to form really strong partnerships with our local connector entities. So every state has that has embarked on these efforts has local connector entities, and they're kind of the hub of information, and they serve as a bridge of communication between the exchange and Medicaid in your respective states. And really just recognizing that the first time may not be the only time in which you have to interact with a client, that you want to try and get all of the vital information on the first interaction, but that you want to make sure that you are connecting with that client until that Medicaid is turned on. And by having these individuals, these navigators and assisters at health centers, they also then serve as the bridge to care. So we've partnered in places like hospitals with parole and probation. Oftentimes clients go to pharmacies and they were able to get their prescription last month, no problem, and then they show up at the pharmacy this month to get their refill and their coverage has lapsed. So that's how they find. If somebody has an ongoing prescription, they're going to show up at their pharmacy a lot more often than they're going to show up at their doctor's office. So that might be how they find out. And then they're going to come back to you because you are their trusted providers. And they're going to say to you, what do I do, my insurance, how do I get this medication? I need it for my blood pressure, my diabetes. And as I said, sites that don't often provide health care but provide really essential services often are seeing these clients who most need assistance in navigating these clients through the process. So in terms of delivering the care, getting the care is one thing, delivering it is the second. And Barbara's touched upon a lot of these things. So just the lack of education of their conditions, a lot of times clients are being seen in emergency departments or in more acute care settings, and they're not looking at kind of the ongoing chronic conditions that they might be suffering from, and there's so many co-occurring conditions that clients present to emergency departments, and what they're getting treated for is inebriation, but really what's going on is that they are using it to treat their mental health, or they're using it to treat their homelessness, to survive spending nights on the street. My advice to you is to find ways to partner with your navigators and assisters in your local regions, with your CACs, posting flyers, even just in your coordinated access. If you include the basic question, do you have insurance, that's going to serve as a perfect springboard to connect clients with these providers. And we've found that educating staff as well as clients is essential. I worked in a HUD-funded program before I came to Healthcare for the Homeless, and I didn't know how to check someone's insurance status. There was a lot of things that I didn't know. And so providing education to the staff who already have those relationship building. So help find ways to educate your staff so that the relationships that they already have, they can help educate their clients. Work with those providers to develop tracking systems, and then invite them to come to your sites regularly. That is the most important thing that you can have so that your clients know if you missed it this week, there's going to be an opportunity next week. So with that, I'm going to turn it back to Barbara.
And I know that we're coming down on our time, so at this point I'll just turn it over to Kristin, Senior Project Associate, and to take it away about SOAR.
All right, thanks, Barbara. We're really excited to be partnering with HUD on this important webinar. Donna, Jessica, Barbara, and Katie have all really done an excellent job describing the importance of enrollment and how you can be a key part of assisting people in getting connected to health insurance. So I'm going to spend a few minutes this afternoon talking about people with disabilities and the importance of Social Security disability applications in light of the Affordable Care Act. So as most of you probably know, there are two key federal health care programs for people with disabilities. We've been talking a lot today about Medicaid, and Medicaid is available in expansion states for adults who have low income. However, Medicaid is also available, like Katie mentioned, to categorically eligible individuals or people with disabilities. So for our purposes today, I'll be focusing on people with disabilities who are eligible for SSI. In most states, eligibility for SSI confers eligibility for Medicaid. So what that means is that Medicaid eligibility is automatic upon SSI approval in 32 states. So in these states, the SSI application is the Medicaid application. In 7 states, they use the same eligibility rules as SSA uses for SSI, but they require a separate application. But so long as you file both applications and are SSI eligible, you should be Medicaid eligible as well.
And then the final 11 states have established additional rules, and they require a separate application. So Medicaid eligibility is not a sure thing upon SSI approval for those programs, for those folks, excuse me. The other federal program is Medicare, and individuals who are eligible for SSDI are eligible for Medicare 2 years after their benefits have begun or when they turn age 65. There are 2 exceptions to this 2-year waiting period. Medicare eligibility begins immediately for people with ALS and end-stage renal disease. So establishing eligibility for SSI or SSDI can really be key to connecting with Medicaid or Medicare health insurance for those folks who are not in an expansion state. So as you heard from Barbara, focusing on health insurance and healthcare enrollment will lead to consumers accessing preventative health care, can help avoid emergency room usage, helps the consumer build relationships with physicians, and really supports people to stay healthy and improves the overall health of the community. It's an important thing to focus on. So I'm going to turn now to how SOAR fits into all of this. SOAR stands for SSI, SSDI Outreach, Access, and Recovery. It's a SAMHSA-sponsored program that focuses on increasing access to Social Security disability benefits for individuals who are experiencing or at risk of homelessness. SOAR is active in all 50 states, but each state is at a different level of implementation. There is no direct federal funding for SOAR, and so the SOAR TA Center works with states and communities to really develop plans for implementing the program through TA training. I'll talk more about that training in a couple minutes. So through community collaborations, partnerships with the Social Security Administration and disability determination services and medical providers, SOAR-trained case managers have been able to successfully assist over 22,000 people to get approved for benefits on their initial application. As you all are probably well aware, and as Katie alluded to, the Social Security disability application process is complex. For unassisted applications from people experiencing homelessness, the average approval rate on initial application is only about 10 to 15%. And the national average for all applications isn't much higher, only about 27%, okay, 26.7%, so we can round it up. Most people are denied on their initial application. However, the national SOAR approval rate is 65% in an average of 94 days. And the top 10 SOAR states have an average approval rate of 82%. SOAR is really about getting it right the first time. So let's quickly turn to the disability programs. The Social Security Administration, or SSA, offers 2 disability benefit programs, SSI and SSDI. SSI, or Supplemental Security Income, is a needs-based program. The benefit amount is based on a maximum federal benefit rate, and in 2015, that rate's $733 a month. Like I mentioned, SSI eligibility is linked to Medicaid eligibility in most states. SSDI, or Social Security Disability Insurance, is an insurance program for people who have worked and paid into the system and some eligible family members. The amount of the benefit depends on earnings put into the SSA system, and SSDI recipients are eligible for Medicare generally 2 years after SSDI eligibility begins. So why are these programs so important? They first and foremost provide access to income, but income leads to so much more. So for people experiencing or at risk of homelessness, this income means access to housing. And in states without expansion Medicaid, it means access to health insurance, which means access to treatment. This access to disability benefits also means access to employment services and other key support services. So for people with disabilities, SSI and SSDI can really be a critical step towards ending homelessness and promoting recovery. We help people access SSI and SSDI because of the benefit it brings to them individually. However, increasing access to federal mainstream benefits is really important for states and communities as well. We all know that people experiencing homelessness are frequent users of expensive and uncompensated health care. And providers can recoup the cost of this care from Medicaid for up to 90 days retroactive to the date of SSI eligibility. We've had some SOAR providers tracking these reimbursements, and last year saw average reimbursement of $10,465 for each approval. Additionally, states and localities can recoup from SSA the cost of public or general assistance that's provided during the application process. SOAR providers tracked this amount last year as well, and it averaged $1,217 per approval. So besides these specific reimbursements, having SSI, SSDI, and Medicaid dollars coming into local communities and community programs makes a big difference in budgets and local economies. You've already heard that the Affordable Care Act has brought expanded access to Medicaid in 28 states and D.C., which means that low-income people in these states can access Medicaid much more quickly and easily than before. However, income benefits such as SSI and SSDI remain critical to accessing safe and stable housing. Barbara mentioned that housing is healthcare in so many ways, so we need to be sure that we focus on the housing piece too, and we get people housing by getting them income. So people in housing who engage in treatment, they're going to have better health outcomes and use treatment services more effectively. So SOAR-trained case managers are especially poised to help individuals who are homeless enroll in Medicaid and continue to help consumers access disability benefits and disability income. We want to encourage you not to let Medicaid enrollment divert your community from the importance of also accessing SSDI and SSI benefits for those individuals who are eligible. Like I said, SSI and SSDI income support remains essential. So in expansion states, consumers should also definitely enroll in health coverage as soon as possible. So this quick access to Medicaid will mean access to treatment and evaluations and additional evidence that can be helpful in supporting their disability application. And then once that consumer is approved for SSI, they can change their Medicaid coverage based on their eligibility for SSI. They should just be sure to indicate that they're disabled on their original Medicaid application. So a quick word on SOAR and HUD's continuum of care. SOAR is definitely a COC priority. In 2014, SOAR training and leadership are scoring items, as most of you probably know, and in 2015, this will be expanded to include performance reporting as well. And we've had great success partnering with COCs to help coordinate SOAR implementation in the community. We've provided targeted TA to over 30 COCs and are currently evaluating applications for an additional round of TA for this year. We've also been encouraging COCs to incorporate SOAR into their coordinated entry and assessment systems. And we recently hosted a webinar last month that you can watch on our website that provides some examples of how COCs have already done this. So a real quick word on the SOAR online training. I won't go into all of the details, but it is available online. It is free. It comes with 16 CEUs from the NASW, includes the completion of a practice case application, and is a really great way to get connected with SOAR. There's a Class 1 offers kind of a SOAR 101 and is a great option for supervisors or administrators who want to get some basic information about how SOAR might work in their community and what kind of commitment would be required of it. We encourage you to get involved with SOAR in your state. So if you follow this web address, you can search by state to find your SOAR TA Center liaison, your state team lead, and really get connected with SOAR in your community. If you have any trouble accessing that information, you can also just contact me directly, and I'm happy to make direct connections for you. And my contact information is here. So I apologize for breezing through that as quickly as I could in the interest of time. So thanks so much for listening.
Thank you so much, Kristin. I know there's still a lot of you out there and really appreciate you hanging in. This has been a lot of information that we've gone over in a quick period of time. I just want to delve into a few questions as time allows. We've got 6 minutes left. One of our questions has to do with how do agencies and individuals become certified application counselors? And I'll let Jessica speak to that.
Wonderful. Thank you, Barbara. So if you go to healthcare.gov, at the bottom of healthcare.gov, and there's a place where it says, for partners and organizations, I believe, and you can sign up. It's free. It's a 5-hour online training. There's a test at the end, and that applies to most states. Any state that's using the healthcare.gov website, you can become a CAC through that link. Now, you all will have access to my contact information. Feel free to send me an email or sign up for the Enrollment Assister network, and I can send you the information to take you directly to the training screen. But you can find it on healthcare.gov. It's multiple clicks once you get there, so if you do want help, let me know and I'll send you the direct link.
Thank you very much. Also want to collapse a couple of questions about outreach and then following up on client coverage. We've had some questions here about how would you go about expanding your outreach services, and then if you are also involved with clients and want to follow up on their client coverage like Katie had described, where could you do that, or how would that best be done? And so both of those I'm going to turn over to Katie at this point.
These are two great questions, and they really stem back to the relationship building. In terms of the following up on the coverage, this is where the partnership with your local exchanges and your connector entities, whether that's having a particular navigator or assister that you have access to be able to process or do some follow-up work on those applications. The reality is the exchange, these navigators and assisters, they want these benefits to become active. And they're receiving so much information that a lot of times you actually have to draw the case to their attention for them to raise it and process it, move it forward. So a lot of times it is just a matter of building those relationships and having somebody that you can call and say, hey, I completed this application 2 weeks ago, and they, we called over to this health center and they said they still don't have insurance, so I can't set up an appointment with them. A lot of times that's all it will take for the exchange or the assister or the navigator to be able to make the next steps to go forward and be able to escalate that application to make sure it goes through. As for developing your outreach, finding other organizations that outreach to your target populations can be very, very helpful. As a continuum, I mean, it's a great opportunity to come together and find out what commonalities you have in terms of populations you serve and how might you be able to outreach to them together and then connect them with not just one but multiple organizations along your continuum. So often in homeless services, our clients rarely access just one provider on the continuum. And so it's a matter of helping them bridge to the continuum and stick to that continuum and then move along it as they need. So partnering with one another, this is a really great opportunity to use your COC meetings to find out where people are. And this is one thing here in Baltimore, as we've started to ramp up our coordinated assessment, we're starting to see the ability to collaborate on these clients, because we had no idea before that a client that's being seen here at Healthcare for the Homeless is also going to the shelter on the west side or going to the meal programs in southeast Baltimore. So having people access through the continuum, this is going to be a really great way to partner on being able to connect your clients to the care that they need.
One final question that we'll put to Jessica has to do with, we've been hearing a lot in the news about an extended enrollment. And while I think all of us have emphasized that Medicaid is a year-round program and you can enroll all the time, many of you are working with clients who are employed, who do have income in non-expansion states. Eligibility will start at 100% of poverty. So really want to make sure that we're all aware of making sure people are getting connected. So Jessica, can you just remind us what the dates on that are?
Absolutely. So if you are in one of the 37 states that uses healthcare.gov, there's now going to be a special open enrollment period from March 15th to April 30th. This is a one-time thing. It's just as people start reconciling their taxes. So if you're in a state that uses healthcare.gov, March 15th to April 30th is when people will be able to apply again. Now, there are different dates for California, Connecticut, Kentucky, Minnesota, New York, Vermont, and Washington. So if you live in one of those states, again, feel free to send me an email and I can let you know what those dates are where people will again be able to apply for coverage.
Thank you very much. We're now at 3:30. I just want to say how much I appreciate so many people turning out for this webinar. I know there's a lot going on at the local level. I'll turn it over to our host, Arula Swice from HUD, just to close us out.
Well, I just want to express my deep appreciation to all of the panelists, not only for your time today, but for the excellent work that you're doing across the country. To our audience participants who stayed with us from the beginning till the very end of this hour-and-a-half webinar, I can see that there's a very strong interest and a lot of commitment out there to improving the way that we coordinate services on behalf of the people that we serve. Your efforts are not in vain. HUD is recognizing this tremendous work that you all are doing in the communities, and we are continually looking for opportunities to support you through guidance, through technical assistance, and this initiative is just one of those examples of how we are just working so hard to support you and acknowledge your hard work. Please stay tuned for additional webinars that will focus on just this topic, how to improve integration and coordination between homeless assistance and healthcare. We will be featuring some successful grantees from across the country, and we're looking forward to spotlighting and showcasing some more of the excellent work that's going on with our HUD grantees so that you all will have a point of reference as you continue to work down this path. Thank you all very much, and please enjoy the rest of your day and make use of these excellent resources our panelists have provided.